Right now in the U.S. alone, we are spending over $10 billion a year managing just a single complication of diabetes, not the disease itself, just one specific complication.
Yeah, it's a massive number.
And for you listening, considering over 500 million people worldwide are living with diabetes, I mean, this is an epidemic that likely affects someone you know, or maybe even yourself. But the wildest part is that this $10 billion crisis is something most people fundamentally misunderstand as just, having numb toes.
Right. It's a massive underestimation. The physical, the emotional, and obviously the financial toll it takes on daily life is staggering. And numb toes barely scratches the surface. We are dealing with a disease that targets the nervous system across multiple fronts, often simultaneously.
So today's deep dive is pulling from a really comprehensive review in the October 2023 issue of the Continuum Neurology Journal.
Yeah.
It's authored by Dr. Melissa Elfros and Dr. Brian Callahan.
Excellent paper.
Yeah, it really is. And our mission today is to take you inside this shape-shifting condition, diabetic neuropathy, and show you how it attacks the body in deeply surprising and frankly terrifying ways.
Terrifying is definitely the right word for it.
So let's start with the one most people do actually think of. Distal symmetric polyneuropathy, or DSPN. The sources say this accounts for the vast majority of cases, and it has a very specific stocking glove progression.
Exactly. It's what we call a length-dependent neuropathy. So think about the anatomy of a nerve cell for a second.
Okay.
The cell body sits near your spinal cord, but it has to send a microscopic cable, an axon, all the way down to the tip of your toe.
That's a long way for a single cell.
Right. That single cable can be over 3 feet long, so it requires an immense amount of energy and a perfect blood supply to stay healthy.
And because those are the longest cables in the body, I'm guessing they are the most vulnerable to the metabolic stress of diabetes.
You hit the nail on the head. They literally start to starve and die from the furthest tips first. Hence, it starts in the toes, spreads up the calves, and then eventually, as other long nerves get affected, it hits the fingertips and the hands.
Wow. So as those long nerves get damaged, the symptoms just slowly creep upward.
Precisely. And importantly, it's not just a loss of sensation. The damage targets 2 very different types of nerve fibers.
Right, the large and small ones.
Yeah, you have large myelinated fibers. These are insulated cables that control your sense of vibration and physical pressure. And then you have small, unmyelinated fibers, which are essentially the raw wires. They transmit pain and temperature.
Meaning, it's not just that you can't feel your foot. You could step on a tack and not know it.
Exactly.
But at the exact same time, the sources say almost half of these patients experience severe burning or stabbing or aching pain from those small fibers misfiring. Reading the clinical descriptions, it's like a slow creeping frostbite, but one you can never warm up.
That's a really haunting way to put it, but it's accurate. The physical numbness is there, but so is the agonizing pain. And that pain is constant.
It's just a dual failure of the system.
Right. You lose the protective sensation you actually need to avoid injury, and you gain a chronic pain signal that doesn't correspond to any actual outside stimulus.
Okay, here's where I want to really look at the mechanics of this. Because we always hear this is purely about high blood sugar. It's a sugar toxicity problem.
That is the common narrative, yes.
So logic dictates that if a patient gets their glucose under control, this creeping frostbite should just stop in its tracks, right?
You would think so, but the source material draws a very sharp distinction here based on the type of diabetes.
Oh, really?
Yeah, if you have type 1 diabetes, strict blood sugar control actually works wonders for preventing DSPN. But for type 2 diabetes, it is simply not enough in isolation.
Wait, so there has to be something else in the blood causing the damage in type 2 patients. It's not just the sugar.
Exactly. The data clearly shows that for type 2, metabolic syndrome is a massive driver of this nerve damage.
Okay.
It's the broader environment of the body that's toxic to the nerves, not just the glucose reading on its own.
So let's look at what makes up metabolic syndrome. We were talking about central obesity, high triglycerides, the fats in the blood, and hypertension.
Right.
So the microscopic blood vessels trying to feed these 3-foot-long nerves aren't just dealing with survey blood sugar. They are being pummeled by high blood pressure and clogged by circulating fat.
Yes. And the research indicates there's a direct dose-response relationship here. The more of these metabolic factors you have, the higher your risk of nerve damage.
Independent of your blood glucose levels.
Independent of the glucose, yes. If you want to actually stabilize the nerve density in a type 2 diabetes patient, diet and significant weight loss are required. If you just fix the blood sugar with insulin, but the patient still has, raging hypertension and high triglycerides, the nerves will just continue to die.
Man, that completely flips the script on how we usually talk about managing type 2 diabetes. It's a systemic vascular problem, not just a blood sugar problem.
It absolutely is.
So DSPN affects the sensory nerves, right? The things we consciously feel in our hands and feet.
Sure.
What happens when the nerves that control the things we don't think about get starved of blood?
Well, then we enter the territory of cardiovascular autonomic neuropathy, or CAN.
CAN, okay.
Yeah. This is where diabetes attacks the involuntary nervous system. It is dangerously stealthy, and when it takes hold, it actually doubles a patient's mortality risk.
Double the mortality risk.
Yeah.
And it does it silently.
Completely silently at first.
The sources describe the late-stage symptoms as profound dizziness and orthostatic hypotension, which is basically passing out the second you stand up.
Yeah.
To me, it feels like a car's internal computer failing. I mean, the engine itself, the heart, is totally fine, but the idle control is broken. So the moment you put a demand on it, like shifting into gear or standing up, the whole system just stalls out because it can't adjust the RPMs.
The mechanics of that analogy are spot on. One of the very first things to get damaged is the vagus nerve.
The vagus nerve.
Yeah, so think of the vagus nerve as the heavy brake pedal on your heart rate. Your sympathetic nervous system is the accelerator, right? It's always trying to speed the heart up. And the vagus nerve constantly pushes back to keep your resting heart rate low and steady.
So if the vagus nerve gets damaged by diabetes, the brake pedal is basically lifted off, which means the early warning sign isn't fainting, it's an unusually high resting heart rate.
Exactly. The accelerator is just running unopposed.
Wow.
Right. An elevated resting heart rate and a blunted heart rate response to deep breathing. Normally, when you take a deep breath, your autonomic nervous system actively manages the pressure changes in your chest.
So your heart rate naturally speeds up on the inhale and slows down on the exhale.
Exactly. But in CAN, that variability is completely lost. The heart just beats at a rigid, elevated pace, completely disconnected from what the lungs are doing.
But since this is so stealthy, and the early signs are literally just a slightly faster heart rate and a lack of variability, how does a doctor actually catch this before the patient is collapsing in the grocery store aisle?
Well, they use a specialized group of clinic assessments called the Ewing Battery of Tests.
The Ewing battery.
Yes. These are simple, non-invasive ways to deliberately stress the autonomic nervous system and see if the computer is actually responding.
Like how?
Well, they'll monitor the heart rate variability during deep breathing using an ECG, as we just mentioned, and they'll use a tilt table evaluation to see how blood pressure physically reacts to gravity when the patient is tilted upright.
And the review also mentions the Valsalva maneuver.
Yes, that's a big one.
I'm trying to picture how this works in a clinic. The doctor asks the patient to bear down, like they're trying to pop their ears or have a bowel movement.
Right.
That creates a ton of pressure inside the chest, which means blood can't return to the heart as easily. So blood pressure should naturally drop.
Exactly. And in a healthy person, the autonomic nervous system senses that drop instantly. It compensates by telling the blood vessels to constrict and the heart to beat faster to maintain blood flow to the brain.
But in a patient with cardiovascular autonomic neuropathy,
the system is blind to the drop. The patient bears down, the pressure falls, and the body does absolutely nothing to fix it.
So if the internal computer is failing and the nerves are already damaged, how do you fix it? I mean, you can't just regrow the vagus nerve.
You can't reverse the nerve damage, no. So you have to manage the sheer physics of the blood flow instead.
The physics, okay.
Yeah, it's a multifaceted strategy. First, you change the lifestyle. You have the patient significantly increase their salt and fluid intake.
Oh, to increase the blood volume.
Precisely. The goal is to physically increase the total volume of blood in their body, making it harder for the pressure to drop dangerously low.
You essentially overfill the tank. And they use physical barriers too, right? Compression stockings up to the waist to literally squeeze the legs and keep blood from pooling down there when they stand up.
Yes, and avoiding hot baths. Because heat naturally dilates the blood vessels, which drops blood pressure further.
Okay, that makes sense.
Now, if physical and lifestyle changes aren't enough, we move to specific medications like midodrine or fludrocortisone.
What do those do?
Midodrine works by chemically forcing the blood vessels to constrict, artificially doing the job the autonomic nervous system used to do. Fludrocortisone is a steroid that forces the kidneys to hold on to salt and water, further boosting that blood volume.
It's incredible how mechanical the solutions have to be when the body's automatic software gets corrupted.
It really is.
So kin is this slow, insidious process developing alongside hypertension and obesity. But if we look at the continuum review, there's a neuropathy that is the exact opposite of this.
Ah, yes.
It's not a slow creep. It strikes suddenly, and paradoxically, it targets patients whose diabetes seems totally under control.
Yeah, you're referring to diabetic lumbosacral radiculoplexus neuropathy.
That is a mouthful.
It is, often shortened clinically to diabetic amyotrophy. It is rare, but it is an absolutely devastating presentation.
The clinical reality of this is terrifying. A patient suddenly experiences acute, severe pain in their hip or thigh.
Just out of nowhere.
Out of nowhere.
Yes.
That is followed quickly by focal weakness that spreads down the leg. The muscle actually begins to atrophy and waste away, and their reflexes vanish. And the sources say it can take up to 2 years just to hit a plateau.
And recovery is often incomplete. The patient might end up needing a wheelchair.
But here's a paradox that really threw me. The data says this frequently happens in patients with well-controlled diabetes who have recently lost a significant amount of weight.
Right.
Aren't they doing exactly what they're supposed to be doing? Why is their body punishing them?
It is a massive clinical paradox, and it's incredibly frustrating for the patient. But the prevailing theory explains why this happens, and it comes down to a very different mechanism.
Okay, what is it?
Unlike the creeping frostbite of classic DSPN, which is, a slow metabolic poisoning, biopsies of the affected nerves in amyotrophy suggest this is driven by microvasculitis.
Microvasculitis. So vasculitis is inflammation of the blood vessels, micro meaning the tiny ones.
Correct.
We are talking about the microscopic blood vessels that directly feed the nerve fibers themselves.
Precisely. For reasons we don't fully understand, possibly triggered by the rapid change in the body's metabolic state during weight loss, the immune system seems to overreact.
So it behaves more like an autoimmune attack.
Yes. Those tiny supply lines become violently inflamed and swell shut. The nerve isn't slowly starving over decades. It is suddenly and acutely choked off from its blood and oxygen supply.
Well, if it's an inflammatory microvasculitis, my first thought is to hit it with immunotherapies. Shut down the immune response, flood them with steroids, and open the blood vessels back up. Does that work?
The data is shockingly limited, and the results are frustratingly poor. Yeah. If caught in the very early acute phase, intravenous steroids might help blunt the initial severe pain. But there are absolutely no proven disease-modifying therapies that alter the long-term outcome or stop the weakness.
That is so tough.
It is. Care ends up relying heavily on aggressive pain management and providing adaptive devices like ankle-foot orthoses or wheelchairs, while the patient slowly waits for the inflammation to burn itself out and the condition to plateau.
That is heartbreaking. You do the right thing, you lose the weight, and your immune system chokes off the nerves to your legs. It's mind-boggling that losing weight could trigger an autoimmune-like attack.
It really highlights how complex these systems are.
But if returning to a healthy weight is dangerous for these nerves, what happens when you aggressively force the blood sugar itself back to normal? Do the nerves panic then too?
Yes. And this is arguably the most startling paradox in the entire review. It's called treatment-induced neuropathy of diabetes, or TND. Right. This occurs when chronically hyperglycemic patients, people whose blood sugar has been dangerously high for a very long time, suddenly turn over a new leaf and rapidly lower their A1C.
For those who might not know, A1C is a blood test that measures your average blood sugar levels over the past 3 months. It basically looks at how much sugar has physically coated your red blood cells.
Oddly.
So a patient realizes their A1C is dangerously high, they finally take their health seriously, they take their insulin, change their diet, and drop that 3-month average down to a healthy range.
And their reward for finally getting healthy is sudden, agonizing, shock-like pain and severe autonomic dysfunction.
It is incredibly cool. Let me show the statistics from the paper because they are stark. If you drop your A1C by just 2 to 3% over a 3-month period, you carry 20% risk of triggering this agonizing nerve pain.
Yes.
But if you drop it by over 4%, you have an 80% risk of developing this severe neuropathy. It's like a scuba diver getting the bends from surfacing too quickly.
That's a perfect analogy.
Right. The diver is returning to a perfectly safe environment at the surface, but the speed of the transition causes nitrogen bubbles in the blood, leading to catastrophic damage.
And just like the bends, the severity and the extent of the symptoms in TIND are driven almost entirely by the magnitude and the rate of that glucose correction. The faster you drop the sugar, the worse the nerve damage.
So if the rapid drop in blood sugar caused the severe pain, what does the doctor do? Do they tell the patient to eat a candy bar and raise their blood sugar back up to stop the pain? Give them some sugar to fix the bends?
No, and that represents a critical clinical tightrope walk. You absolutely do not liberalize the blood sugar. You don't intentionally go back up to a toxic state.
Okay.
But you must stabilize the current level immediately to prevent any further rapid drops.
Why does this happen? If their large nerve fibers look completely fine on electrodiagnostic tests, but they are in this much agony, it has to be a reaction to the sudden environment change. It's almost like the nerves have become addicted to the sugar, and this is a violent withdrawal.
That's very close to one of the leading theories. The idea is relative hypoglycemia. The nerves have adapted to surviving in a high sugar environment. When you rapidly drop the glucose to what we consider normal, the nerves experience it as starvation.
Wow.
They are literally lacking energy at this new baseline. The other leading theory suggests that the sudden shift in the glycemic state triggers a massive systemic release of inflammatory cytokines.
Cytokines being the body's chemical alarm bells that trigger inflammation.
Right. A sudden flood of these inflammatory messengers assaults the small unmyelinated nerve fibers. Those are the specific fibers that transmit pain. So they start screaming, causing that diffuse, burning, shock-like agony.
And it doesn't just stop at the nerves, does it? The review mentions other systems crashing.
Correct. Clinicians have to monitor these patients very closely because a rapid drop in A1C that triggers TID is also highly associated with a rapid paradoxical progression of microvascular damage in the retinas of the eyes and the filters of the kidneys.
The whole system just panics.
The entire microscopic vascular system is shocked by the sudden change in blood chemistry.
Okay, I'm listening to this, and whether we are talking about the slow, agonizing creep of DSPN, the sudden hip pain of amyotrophy that puts someone in a wheelchair, or the electric shock pain of TIND, we are dealing with patients whose daily lives are defined by severe, life-altering pain.
Without a doubt.
And you mentioned earlier that there's no real cure for the nerve damage itself. So how do we actually treat the pain without doing more harm?
Well, the American Academy of Neurology recently updated their guidelines for treating painful diabetic neuropathy. The strategy relies heavily on four main classes of non-opioid medications.
Okay, what are they?
We have gabapentinoids, like gabapentin and pregabalin. We have SNRIs, which are traditionally used as antidepressants, like duloxetine. We have older tricyclic antidepressants, like amitriptyline. And finally, sodium channel blockers, like oxcarbazepine.
Let's break down how these actually work, because it's fascinating that we are using antidepressants and anti-seizure meds for nerve pain.
It is really interesting.
For example, sodium channel blockers. A nerve fires a pain signal by opening microscopic gates that let sodium rush into the cell. If a nerve is damaged by diabetes, those gates can get stuck open, firing pain signals constantly. A drug like oxcarbazepine literally acts like a wedge, jamming those sodium gates shut so the nerve can't misfire.
Exactly. You are chemically altering the nerve's ability to transmit the false pain signal. Gabapentinoids work similarly by binding to calcium channels to calm down hyperactive nerve transmission.
And what about the antidepressants?
The SNRIs, like duloxetine, work entirely differently. They increase the levels of serotonin and norepinephrine in your spinal cord. This essentially turns up the volume on the brain's natural downward pain inhibition pathway. It helps the central nervous system say, ignore that signal from the leg.
The review mentions a recent trial called OpSham-DM. What did that tell us about choosing between these drugs?
It was a highly impactful trial because it proved that all four of these classes of medications are generally similarly effective at reducing neuropathic pain. But more importantly, it showed that if one drug isn't enough, adding a second agent from a completely different class, say, combining a sodium channel blocker with an SNRI, can significantly improve pain control.
That makes sense.
It gives doctors a flexible arsenal to attack the pain from multiple angles while managing side effects.
I understand the pharmacological arsenal, but I have to be honest. I'm thinking about a patient whose hip is in so much agony they can't even stand up. Or someone suffering from those subtle electric shock pains of TID.
Right.
Telling them we're just going to tailor some antidepressants and anti-seizure meds and wait a few weeks for them to build up in the system. It sounds almost cruel. If the pain is an emergency, why isn't the immediate response to use a heavy-duty opioid like tramadol or oxycodone just to get them out of their misery quickly?
It is entirely understandable to want to eliminate that suffering instantly. I get it. But based on the clinical guidelines and the massive body of evidence we are reviewing, prescribing opioids is a hard no.
A hard no.
Opioids are explicitly not recommended for diabetic neuropathic pain, even in severe cases.
Why? Is it purely because of the addiction risk?
It's the catastrophic ratio of risk to reward. First, there is remarkably limited data showing any genuine long-term effectiveness of opioids for this specific type of nerve-generated pain.
They don't actually work that well for you.
Right. They don't actually fix the misfiring sodium channels or boost the downward inhibition pathways effectively over time, and the downsides are profound. We are talking about the risks of overdose, abuse, severe addiction, and death.
Wow.
Diabetic neuropathy is a chronic, lifelong condition. If you put a patient on opioids for a pain that isn't going away, you are setting them up for a lifelong dependency where they will constantly need higher and higher doses for diminishing returns on pain relief.
So the strategy isn't to obliterate the pain entirely, because doing so might destroy the patient's life in a completely different way.
Precisely. The strategy must be careful, titration of the approved non-opioid drug classes, often using them in combination. But crucially, it's about setting reasonable expectations with the patient.
Right.
The goal is rarely zero pain. The goal is manageable pain that improves their quality of life, allows them to sleep, and lets them function without exposing them to the catastrophic systemic risks of long-term opioid use.
Okay, let's unpack everything we've explored today. We set out to shatter the idea that diabetic neuropathy is just numb toes. And the continuum review by Dr. Elfros and Dr. Callahan absolutely dismantled that myth.
Completely.
We've seen how it is a massive, complex spectrum. You have the creeping stocking glove numbness and agonizing pain of DSPN, driven not just by sugar, but by the toxic soup of metabolic syndrome. You have the silent, deadly failure of the involuntary nervous system in CAN, where the heart literally loses its brakes. You have the perplexing autoimmune-like microvasculitis attacks of amyotrophy in patients who are actively losing weight. And finally, the incredible danger of fixing blood sugar too fast, resulting in the violent, shock-like pain of treatment-induced neuropathy.
It's a really comprehensive look at how deeply integrated our metabolic health is with our nervous system. Every nerve, from the 3-foot-long cables reaching your toes to the microscopic fibers regulating your blood pressure, is profoundly vulnerable to the environment we create in our bodies.
And that leads me to a final thought for you listening to mull over as we wrap up today's deep dive. The exact mechanism behind treatment-induced neuropathy, getting the bends from dropping your blood sugar too fast, reveals something profound about human biology.
It really does.
It shows that our nervous system can adapt to a toxic, high-sugar, high-stress environment so thoroughly that returning to a normal, healthy state suddenly registers as an existential threat. It really makes you wonder, how many other chronic, unhealthy states is the human body quietly adapting to right now? And what hidden shock might happen when we finally try to fix them?
It is a fascinating and somewhat daunting question. The body is always seeking equilibrium, always trying to adapt to survive, even if that equilibrium is slowly destroying it from the inside out.
Exactly. Something to keep in mind the next time someone tries to tell you diabetic nerve damage is just a numb toe. It's an entire system fighting to survive.